occupational safety by globally famed speaker, Dr. Raghunath Putai. We extend a warm welcome to Dr. Raghunath with gratitude for giving his valuable time to the fellows of ICD Section 6 and the members of the IDA Chandigarh State Branch. In spite of your not keeping good health, Dr. Raghunath is from the School of Public Health and Diagnostic area of Oral Health. He has a great leadership quality in conducting online training program in dental infection, occupational safety, and health administration, health insurance, portability, and accountability act. We are honored to have you on board and thankful to you. We are delighted to acknowledge Dr. Joseph, our Secretary General, and Dr. Chelsea Sovereign, Director from the head office ICDA. Both has helped us in planning this program. Dr. Joseph was to join the meeting. Only few hours back, I received the message that he is traveling and he has sent a recorded video. We would like to display it after my speech. It is our pleasure to extend a cheerful welcome to Dr. Anil Coley, past President, DCI, and our Counselor to Head Office ICD, Dr. Mahesh Verma, Vice Chancellor, IP University, Delhi, and Chairman of Continuing Dental Education of ICD Section 6, Dr. Rajesh Chandna, past President of ICD Global, and Dr. Rajiv Chok, Secretary General, ICD Section 6. They all have lot of contribution in making this program a grand success by remaining in contact with the speaker, the leaders of the head office. Sir, we are indebted to you all. It is our pleasure to welcome the Board of Regents, Executive Committee members of ICD Section 6 and IDA Chandigarh State Branch. Their constant suggestions, advices, motivation have always given a courage to do more and more academic, cultural, and social awareness program. Most of them have given suggestions, ideas, and help in getting the registration of the viewers unbelievable. We are grateful to you all, sir. Here I wish to place on record the Secretary of the Chandigarh IDS and our fellow Dr. Arpit Gupta for his unstinted support. He is working from the last 2-3 months for this webinar, and you will not believe it. Yesterday he slept at 3 a.m. just arranging this program. And here I also want to your knowledge, I want to inform you that I am also proud of my Chandigarh team, the whole team, which consists of past leaders, present leaders, for performing any duty diligently whenever they were requested. I am grateful to all of them. Sir, these are the first virtual certificate program on the topic infection control in the history of ICD Section 6, completely conducted on digital platform in line with social distancing norms due to COVID-19 pandemic. New technology is constantly emerging, while adaptation and application may be difficult. These webinars shall discuss many advancements and touch new techniques to help provide insights into our day-to-day practice. In these weekly seminars or webinars, infection control expert Dr. Raghunath, representing the Organization for Safety, Asepsis, and Prevention, will provide the viewers from the international dental community with practical guidance and education, as well as navigate the challenges that COVID-19 is presenting in our professions in today's time. Thank you all. Jai Hind ICD, Jai Hind IDA. Now over to Dr. Arpit. You can relay the video received from the Dr. Joseph.
Thank you, sir, for your words of motivation motivation. And with this, I'll start this video, which we have received from the ICD head office.
I'm Dr. Joseph Keneally, the Secretary General of the ICD. It is my pleasure and my honor to present this greeting and introduction to this wonderful series of presentations on infection control by Section 6, India, Sri Lanka, and Nepal. I've now made several visits to India, and I always return home impressed by Section 6 and its members. The section has so many educators and researchers, contributions to scientific knowledge that are mentioned. After my first visit to New Delhi, it was the 2001 International Council. I traveled through Rajasthan afterward with my wife, Dr. Lisa Howard, our friends, the late past presidents.
Taking the program ahead, I would like to call upon the former President of the Dental Council of India, Dr. Anil Coley, who is also the International Counselor for the ICD Section 6, for his welcome remarks. Dr. Anil Coley, please.
Thank you, Arpit. And thank you, Dr. Gupta, the President, ICD Section 6, Dr. Mahesh Verma, the Vice Chancellor of Indraprastha University, Dr. Rajesh Chandana, and Dr. Rajiv Chuk. It's a very wonderful program which has been organized. It is a need of the hour and very well thought topic has been chosen in the COVID times. Coming to the speaker, the Raghunath Kutaya is a well-known person in public health dentistry. He is a renowned infection control expert in the world. I should call him as a dawn of infection control. I know him for almost 3 decades. And why I say that? Because Raghu has seen the 3 things in life. One is HIV/AIDS time, then he has seen the Ebola, then he has seen the H1N1 and the SARS, which is called the SARS. And he has framed various rules and he has published many papers. He has done very research abstracts. And we, together with Dr. Mahesh Verma, myself, and Dr. Kutaya, we have published a book in 2007 for the dentist on the infection control and occupational therapy relevant to the Indian scenario. We are looking forward to hear Raghu, who is really a very dear friend and very good speaker. This afternoon I was listening his lecture for 1 hour, which he gave, I think, in Taiwan or somewhere for 1 hour about infection control question answer. And it's very interesting. I think in today's time, what we need to know the new norms because we have to live in the present circumstances because every time the lockdown is being extended, people don't know what are the norms, how we will go back to the practice, what is going to be the future. But all we are the professionals. We are well versed with the infection control methods and we will know what is the life going to be after this COVID or if we have to live with the COVID, for how long we have to live. I may not be taking much of your time. I welcome Raghu and we are looking forward to hearing. Thank you, Dr. Gupta, for welcoming me and Dr. Arpit, you are doing a wonderful job.
Thank you, sir. And next, we would like to call upon a gentleman who needs no introduction. He had been the only Indian to be the president of the ICD head office, Dr. Rajesh Chandana.
Thank you, Arpit. Good evening, dear ICD fellows, IDA members, students, colleagues, and all those attending the program. This event by Raghu, who is a leader in infection control, exemplifies the type of international collaboration and we need to address the infection control issues, not only in India, across the world, and to make it a primary issue. ICD, along with IDA, has been always in the forefront in conducting these infection control and occupational safety programs. Raghu obviously needs not too much of a introduction, which already Dr. Anil has given me, but he was my senior fellow in college and we met after 25 years and he was inducted in India in 2011. Soon after induction, he started serving ICD and gave all his research and papers and publications to ICD as a selfless service and he was appointed to conduct the infection control programs. One of the programs many of you may have remember was conducted in India in around 2016, which was known as Train the Trainer. It was a wonderful 2-day program with leading academicians.
नमस्कार जी, मैं आपको 5 मिनट में करूँ, मैं एक लेक्चर में हूँ जरा.
With leading academicians attending the course, again on infection control. I would like to really thank Dr. R.P. Gupta, who has been in touch with Raghu and Joe Kennelly, our Secretary General, International Secretary General. And my grateful thanks to Joe, R.P. Gupta, Dr. Anil Kohli, Dr. Mahesh Verma, Rajiv Chuk, our Secretary, and a special thanks to Arpit, who has been really working so hard until 2:30 a.m. I think we were still on emails and trying to get things organized. Thank you very much. I hope all of you enjoy this program and keep it's very informative and good insight and a thorough insight for infection control. Thank you.
Thank you so much, sir. And next, we have somebody who is rightly called as the pole star of dentistry in India. And yes, I'm talking about Professor Mahesh Verma, the former director principal of Maulana Azad Institute of Dental Sciences, and he is the present vice chancellor of IP University at New Delhi, and also he is the chairman of CDE at ICD Section 6. So I would request Professor Verma to chair this session and take the proceedings ahead. Professor Verma, please.
Thank you, Arpit. Esteemed Dr. R.P. Gupta, President of ICD Section 6 and IDA Chandigarh branch, Dr. Anil Kohli, International Counselor, Dr. Rajiv Chug, Secretary General ICD, Dr. Rajesh Chandna, past President ICD Head Office, Dr. Arpit Gupta, Secretary IDA Chandigarh branch. I also see Dr. Yogesh Vermani, Deputy Secretary, Dr. Bali, past President of ICD Section 6, Dr. Meera Verma, other fellows, colleagues connected for this program. First of all, it's such a wonderful feeling, to chair and to to have this program during this gloomy time. You all know that what we are going through, and I think it is very pertinent because although the dentistry is a surgical specialty and control of cross infection and safety is a very strategic fundamental for education and practice, but I think if there is one single event which has really shook the world, which has really drastically brought everyone to the knees, is Corona pandemic. As Dr. Coley said, that we've had so many other pandemics earlier, HIV, MERS, H1N1, but I think something which has really brought the entire world to a standstill is this Corona. And, we all know that we have struggled hard, during this time, especially from infection control point of view. And we are still trying to figure out how we can ward off and protect ourselves, our staff, our patients. And may I say that we are still groping in dark. And I think this particular event has given a new fillip, a new lease of life to the entire game plan of infection control and safety, when we look at that from present perspective. Also, I'm sure you all familiar that we have a black fungus, mucormycosis. That's again something to be, that is again has really augmented the reality of infection control. So this is one part. The second part is that infection control, even otherwise, is a very essential domain for any practitioner to start the practice practicing dentistry, because It's one of the mandatory domains in terms of cognitive, psychomotor, or affective domains. And we also tend to take it easy sometimes because, we develop sometimes shortcuts. We just, be laid back sometimes because sometimes it is handled by our support staff and we assume that they are doing everything fine. So I think it's time we need to refresh, reboot, and understand what is the current gold standard, because this is not a static science. It's changing every time, and every new pandemic or endemic brings you new set of information. So that's the second part. And the third relevance is that we all know that as a part of essential skills which we all need to gain as a part of our license, dental licensure, it is one of the essential credits, infection control, and that was started by Dr. Anil Coley, I remember. So, we got to do that. We may be a prosthodontist, orthodontist, endodontist, or a oral surgeon. I think the lifeline of practice is infection control. Your outcomes are not going to be wonderful, not expected unless, you practice infection control very well. And, many of us think, what is there in infection control or as occupational safety? As Dr. Coley said, that, it's a blend of numerous areas, whether physics, chemistry, biochemistry, or bacteriology, virology, physiology, medicine, epidemiology, behavioral sciences, so many things, all blend of all that. And so, as I said, that this is not static science. This is dynamic, and I think we need to acquaint ourselves. So, to bring this such a fantastic information, we have Dr. Raghu Putia here today amongst us. He is, he is bringing the information to all of us, our fellows, our professional colleagues, very incrementally building it. He will cover the entire certificate program in 5 parts. The first week, he will talk about rationale of dental infections and how is it going to impact the dentistry. In the second week, he's going to talk about epidemics, endemics, what happened in the past, what is happening now, and what are we anticipating in future. How do we use germicides, and how do we misuse them? How do we use them? In the third week, he's going to talk about the safety part. That means PPE and powered respirators. These days, we are somehow not very popular in India, but there are PAPR, which are very popular in America. So let's learn all about that. Barriers, hand hygiene, that will be covered in the third week. And in the fourth week, he's going to talk about water sanitation, water lines, contamination. How do we sterilize the instruments? How do we monitor it? How do we release the instruments? How do we ensure that the sterility of the instruments is preserved? And finally, the fifth week is the most important part, which is antibiotic stewardship and antimicrobial resistance. The entire world is talking about AMR and ABS these days, and I'm also slightly working about it in FDI. So I think what I say, this is Corona काल में संजीवनी बूटी लेके आए हैं हनुमान के रूप में, from Dallas to Delhi and from Texas to Indus, to India, from Texas to Indus and from Dallas to Delhi. Raghu Putia, everybody has introduced him nicely, but I would like to slightly introduce him a little more, that he went to US, he did his MPH from University of Alabama at Birmingham, and he was among the first one who got this J&J award in infectious fellowship, and he completed his fellowship at University of Texas Health Sciences Center at a very top-notch dental college of US, San Antonio. And then he was working at the dental school in Texas, and he recently relinquished as a tenured professor of public health sciences. And he's contributed a lot. And Dr. Coley said that not only he has helped us in terms of courses and books. And he was probably the first one when Dr. Coley was the president of the council that who crafted the dental safety standard, which were, I think, released by Prime Minister at that time. And he is a global speaker. He is a guru. We all admire him because he has traveled and he has extensively lectured all over the world. And he is a reviewer for many journals, JADA, Journal of Dental Education, Journal of Contemporary Dental Practice. And he is also made manuals for quality assurance, quality control, checklist, OSHA, HIPAA, rules, acts, and he's a proud ICD fellow. As Rajesh said, that he was inducted here in India in 2011, and ever since he's been looking after scientific director of dental safety program and a train the trainer program for ICD fellows at ICD head office. I know him personally. He's a dear friend. He's happily married to Radha. A couple of years back, we celebrated their anniversary here in Delhi, and I brand him in 4 B's. What is that? He's a benevolent, he's a benign, he's a bindas banda. 4 B's: benevolent, benign, bindas banda. And हमारे लिए तो मैं ये कहूंगा कि वो रघुराम पुत्र बन के आए हैं, रघुनाथ पुतैया. जो रघुनाथ पुतैया बन के आए हैं. So in this gloomy period, he has come us to show us the light that how do we move forward and look after the infection. At this juncture, Raghu, such a pleasure. Floor is all yours. Over to you, Raghu.
Thank you.
Very good.
Thank you. Arpit, can I share my screen now?
Yes, sir, you can straight away go ahead.
Okay. Can everybody see the screen? Arpit?
Yes.
Okay. Thank you, everybody. It was a wonderful introduction, and I sincerely thank everybody, who helped me get into ICD, do my humble trainings, in whatever little ways, like a single half-hour lecture or a keynote address, all the way to, what do you call it? A 2-day train the trainer program, help develop the standards for dental safety in India. So I need to humbly thank all of you for helping promote this, I'd say a godforsaken subject, which everybody thinks, we need to just get our certification and move on. No, it's not. It is something which is integral to every aspect of dentistry. It's patient safety, it's employee safety. Okay. And I need to actually thank 2 people as well who helped mold me in dental infection control. My mentor in infection control, infectious diseases during my Johnson & Johnson fellowship in San Antonio for 4 years was Dr. James A. Catone. And today the best-selling book is called Catone's Practical Infection Control in Dentistry. The other person is the late Mr. Walter Bond, who was the head of hospital infections at the Centers for Disease Control. He was an amazing, hard-nosed, excellent infection control, infectious diseases person. He was the one who used to gear up people to go and, combat Ebola in Africa, way back in time. So, and I thank the International College of Dentistry, of dentists, basically, the head office, for giving me the opportunity and a leadership role for a few years in molding the dental safety program. And I thank all of you attending, and I hope you stay for the next 4 lectures after this. It is an important thing. It's not just to fill your boring time, but it's something to learn. You may know a lot of it, but there is always something to know. So please keep an open mind. Let's talk a little bit about the history of epidemics and pandemics. I'm talking not of, just a simple influenza and so on. These are the diseases that pop up all of a sudden when nobody's expecting. During the height of your social living, your wealth, your richness, your benevolence, and all these things. A disease comes from nowhere and strikes and kills
And
multiple scores of people.
I'm sorry to
Uh,
interrupt, sir. May I, Raghu, sir? I think
yeah,
some people are complaining of low audio. So can you just try to hold your mic a little bit closer or something? Because I just got a couple of issues
sure, sure,
regarding that. Thank you so
sure.
much. Apology.
No problem. Can you hear me now?
Yeah, but
Okay. So the issue is not purely what we can do at any given time against a disease. The disease actually takes over. Some of these are diseases that are spread from people to people. Some are zoonotic diseases that actually come from animals when we encroach into their territory or when there is a cataclysm of things in their territory. They come into where we live. So let's go ahead and look at the classic diseases. In 429 BC was the plague of Athens. It killed thousands and thousands of people. In 165 AD, the Antonine plague. In 541, the plague of Justinian. You may want to look at all these things. Just Google them and study about them. You'll understand that you're going to be prepared to face all these things with whatever knowledge we have. Then we had the Black Death. Then we had smallpox and measles, in the New World, that is the Americas, where it was introduced from the Old World, from Europe. Then there was cholera, Spanish flu, HIV and AIDS, which is still going on. It may be under control in a few countries, but in most countries, it's still ravaging, people's lives. Then in 2003 was SARS, then MERS, then Zika, then Ebola, then measles again in the USA. Okay, and of course, worldwide today is our famous COVID-19, SARS coronavirus 2. As Michael Osterholm put it very clearly in 2003 when he saw SARS, he said there's going to be a big disease that is going to strike us pretty soon. He is from the Center for Infectious Diseases Research and Policy from the University of Minnesota. And he puts out a podcast almost every week. And he's probably one of the foremost infectious diseases epidemiologists in the world, where multiple advanced countries want him as a consultant. And he's a brilliant man. And I've had interactions with him when I was doing my fellowship as a little fellow in San Antonio. And recently we had him, at Texas A&M College of Dentistry to come and speak as well. So the infectious diseases are going to hurt us. They're going to shake our systems. They're going to shake the political, financial, and social systems. And there will be a lot of ethical issues as well. Okay. Now, in the subjects I teach on dental safety, I'm purely going to concentrate on infection control, which encompasses both patient safety and employee safety. Okay. If you look at this mind map, we'll talk today about the rationale of infectious diseases in dentistry. Okay. So, infectious diseases have changed the course of history. We know that. Today, SARS-CoV, the SARS-2 or COVID-19 has changed everything. But if you look back into the 15th century, when the Spaniards, found the New World, America, Hernan Cortes, he was one of the, it's not Christopher Columbus, but it was the other guys who came after. That was Hernan Cortes and Francisco Pizarro. They came from Spain with a few conquistadors and changed the course of history in the Americas. When Hernan Cortes came, he actually heard about a city-state called Tenochtitlan. Tenochtitlan is nothing but Mexico City. At that time, it was ruled by Montezuma. Okay. They spoke a language called Nahuatl. Okay, Nahuatl, remember this. And when Hernan Cortes befriended Montezuma, he became a guest of the city-state. He dabbled in the politics and was asked to leave. But soon he came back with only 2,600 of his soldiers or conquistadors and decimated 80,000 Thunderbird warriors. Thunderbird warriors of that time, Mexico City, were nothing but crack troops. They were solid, huge, and powerful. 80,000 of them. How did he do that? When he first came in, unfortunately, smallpox was introduced into Mexico City. Most of the able-bodied population either died or were crippled for the rest of their lives. The people protecting Mexico City were not Thunderbird warriors. They were younger kids who acted that they were Thunderbird warriors, probably. And that's how he decimated it. Today, the second language in America is Spanish. If it wasn't for smallpox, it would be a language called Nahuatl. Now, there are pioneers in modern infection control in dentistry. Ignaz Semmelweis, Joseph Lister, and prior to that, of course, was our own Shushruta, from India. Ignaz Semmelweis was a neonatologist. He served as a faculty in Vienna, the Vienna General Hospital, which was a teaching hospital. At the time, he saw that close to 20% of the inpatients either picked up the disease and died or were crippled. And then he soon realized that the doctors in training, or the medical students of that time, first used to go to the morgue to do the anatomy stuff on fresh dead bodies. They were not preserved dead bodies with formaldehyde and other chemicals. These were these were recently dead people who were putrefying, but they went ahead and cut them up, touched those bodies, and there were a lot of disease, a lot of infections, a lot of microbes. Okay? At that time, they didn't know that microbes caused the disease. At that time, they thought miasma, a phenomenon called miasma or bad air, caused diseases. That's why they used to, whenever there was a plague, they used to shut the doors and windows so that the bad air would not come in. So that was the science at that time. Okay? Ignaz Semmelweis put a big tub of a chlorate of lime, basically a mild bleach solution, and told all these doctors in training to first, dip their hands and rinse their hands in that, and then come and handle the patients in his ward, okay, the neonatal ward. He brought the disease rates all the way from around 18% to 2%. And he was so happy. A lot of people liked what he did. A lot of people did not like what he did. It was the people who did not like what he did was also one of his supervisors, who was the director of the hospital, who said that this guy is crazy. So he got him admitted to an asylum, a mental asylum in Vienna for a couple of years as the ward of the state. There, Ignaz Semmelweis broke down. I mean, all of us have faced things like this in life. He broke down and he said, murder must cease. And then when he was released, he went back to Hungary. If you go to Budapest, please try and visit that statue of his, Ignaz Semmelweis. Okay. About 15 years later, Joseph Lister did exactly the same thing in Glasgow General Hospital. And instead of chlorate of lime, of course, he used a mild phenolic, like a carbolic acid. And guess what? He was accepted as a hero in infection control, controlling diseases, the spread of disease. Today, even a mouthwash, which has got nothing to do with Joseph Lister, is called Listerine. It's available everywhere in the world. Now, infection control is not a new phenomenon or a new finding. People in China, people in Egypt, people in India, all these places, older civilizations, they had measures to control. One example is Sushruta. Okay. The thing about Sushruta was he was a surgeon and he also practiced. I mean, he designed a lot of the dental instruments also, which we use, like the forceps, come from his design. The nose job, which we all get, is actually his procedural design. Okay. So what he used to do is before he did any surgery, he used to fumigate the place, with frankincense and so on, which was available, which we still use in India. After a weekly bath with oil, we use frankincense, the smoke, to actually clear up. Then he also painted the surface, cleaned the surface, the surgical area where he was going to lay his incision with possibly, plant extracts such as turmeric, probably, because turmeric we know is there. But there were other plants also. He used to flame probably his instruments before he went ahead and laid the incision. What he practiced was cleanliness. Okay. So it was there then, but it was during the dark ages between the 7th century and the 15th century, 16th century, when all these beautiful books which were written on medicine or practice of medicine were destroyed, either because of religion or by a ruler who was actually influenced by religious leaders. They called these scientists, witches and warlocks, and they used to burn them at stake. Okay. But of course, today it's a different story. Now, let's talk a little bit about the routes of transmission, disease transmission. We have 4 routes: percutaneous, contact, inhalation, indirect contact. Percutaneous is through the skin, a sharp instrument which is contaminated that goes through your skin and touches the insides, the fascia and the blood vessels of your body. That is the highest risk of disease transmission. Okay. The next one is contact, splash or spatter. Anything like when we're using an air water syringe or a handpiece or an ultrasonic scaler, we use a lot of water, and that water can bounce off the surfaces in the mouth and then land in your eyes, mucosa, your nose, your mouth. If there's an open wound on your mucosa, there could be this transfer. Now, the next one is inhalation. Inhalation of a droplet, inhalation of air contaminated, inhalation of bioaerosols. That is another way of disease transmission. The chances are low, except in very, very strong microbes or viruses like in COVID, SARS or COVID. Indirect contact. For example, I sneeze on a surface and then somebody, puts their hand on the surface and then rubs their eyes. They can pick up a disease. Example could be diphtheria. So there are many, many very infectious microbes around the world. Okay. It's a matter of us contacting it. Now, in a dental clinic, we have to protect ourselves from percutaneous injuries, contact, inhalation, and indirect contact. Okay? That's why we have so many procedures. Now, let's talk about modern infection control and standards. These basically were developed, during the 1960s and 70s because of hepatitis B. I'm talking of the United States experience. Okay, I've studied extensively as a history buff on infectious diseases. Some of the books I read are hospital infections and infectious disease epidemiology. Those are some very strong cases which you can study about. Now, they had developed standards or guidelines to control infectious diseases such as hepatitis B, which was ravaging dentistry. Patients were infecting dentists, dentists were infecting patients. But what happened was in the 80s, they found that hepatitis B could be controlled by immunization. Okay. The minute it came in, everybody forgot the standards. They just got their shots and they knew that they were protected. Okay. But then what happened? In 81, 82, a new disease, a disease with, which had a social stigma, okay, started popping up in the US, in Europe. So what happened was they found that this is the disease, which is today called HIV. It had a social stigma as well. Okay. It was a blood-borne pathogen, HIV, basically. So in late 80s and early 90s, the first set of infection control recommendations were introduced. And the best one, which was in 93, was written by Mr. Walter Bond for dentistry. It's a 30-page document. We'll share all these documents with you as well. At that time, all the dentists quickly started following those recommendations. You know why? Because they didn't want to be stuck by a needle or a sharp instrument while they were treating HIV patients and stick themselves, like in the sense, and then pick up the disease, because this disease was normally found in homosexual males, and they didn't want to be called a homosexual male, maybe, So it had a very strong social stigma. So sometimes social stigma actually makes you conform to standards rather than all the education we try and get. They may not understand the whole thing, but they will do it at least. It's like monkey see, monkey do, Then the CDC came up with that. The ADA followed those standards. They wrote their own standards, but then everybody got together. Then OSHA came into the picture and said employees need to be protected, and they came up with the bloodborne pathogen standards. Okay. Then in the US, every single state's board of dental examiners, said you need to follow these recommendations, the CDC's recommendations and the OSHA's guidelines or OSHA's rules. And you must show proof of that you are taking the CE, continuing dental education, for at least 4 hours every 2 years. Okay. But this is all for bloodborne pathogens. Okay. Around that time, a dentist David Acker had infected 6 patients with HIV. Okay. My mentor, Dr. James Cotton, he actually investigated that case. He was the expert panel reviewer for that case. Recently, I was one of the experts who was asked to review, from the plaintiff's point, an oral surgeon infecting two cases, the first 2 cases of hepatitis C in dentistry. Yeah. Then what happened was we were all following bloodborne pathogen standards, but then in 2003 and 2009, when SARS and H1N1 influenza started shaking the foundations of living in the US, they came up with additional precautions or transmission-based precautions. Okay? So today we follow the transmission-based precautions. Now, coming to the picture in India in 2007, Dr. Coley and we wrote the Dental Infection Control and Occupational Safety for Oral Health Professionals for India. And we actually published, the book was published, and then at that time, the Honorable Prime Minister, Dr. Manmohan Singh, introduced it in his residence, and as a book. And then by 2011, in the India Gazette, we got the requirements for dentists to have continuing education in infection control. But I think nobody followed it. The dentists didn't follow. The schools don't have, even today, a program in infection control in India. Okay. Those are some things which is already there, but we are trying to make something out of it. Why do we do this in dentistry? If you go to a medical doctor's office, first thing they'll do is they'll ask you to fill a form. They'll take your weight and your blood pressure and your temperature. And the doctor will come and auscultate you, ask you a few questions, auscultate you on your chest and on your back. And then, if you're a diabetic, he'll say, go to the lab, draw your blood. We want to see your A1Cs. Otherwise, he'll just prescribe. And there's hardly any requirement for infection control. But in dentistry, what happens is, as soon as a patient comes in, we jump into the patient's mouth, which is full of bloodborne pathogens, right? Yeah, saliva and blood. The minute you start doing your periodontal probing, you can hit blood. Saliva is as infectious as blood as far as dentistry is concerned. Okay? We do surgical stuff. Anything, our handpiece comes out, our scalers come out. Okay? We have to do a surgery. We cut teeth, we cut bone. We do endosseous surgery. Extraction is an endosseous surgery if you think about it. If your instruments are not clean, if your environment is not clean, that's another issue. I'm happy that Dr. Verma brought out this thing of mucormycosis. We have to think about it in multiple ways. The air in your, which comes from the air water syringe or your handpiece, does it have mucormycosis? Because it is humid, it is warm, and that is where these fungi grow. How often do they clean the air lines of the respirators in a hospital? Do we get mucormycosis from that? There is a possibility, and we should request our colleagues to actually test everything. Okay. Now, during the HIV times, bloodborne pathogens, the Centers for Disease Control came up with universal precautions or standard precautions. That is during then normal times, not today's normal times. Apart from all this thing, like, you have to sanitize, you have to disinfect, you have to sterilize, you have to wear PPE and all the good stuff. The most important take-home point in this particular situation was, do not discriminate based on how a patient looks or what kind of a medical history they give. Treat all of them as infectious diseases. These are original pictures I've taken. This was a cowboy in Tombstone, Arizona. This is one ex-student of mine. This is, a professional, performer in Hawaii. This is another endodontist ex-student of mine. And this was my son, who was about 2 years old then. Okay. Whenever I put them in the dental chair, I treat them all as potentially infectious. We don't know. Yeah. We don't test them for bloodborne pathogens when they walk in. We don't take their temperature at that time. We never used to take, to see whether they're suffering. No. If you have a religious nun or from the Mother Teresa order who's sitting in your waiting room, and then you have a guy like this with all tattoos and piercings and all the good stuff, who is the most infectious disease prone person? It is not the person with tattoos or body piercings. It's called art. But it could be the nun, because the minute she wakes up in the morning, she'll go do her prayers, eat something very simple, and then go and start treating patients, with infections. She'll go and hug the homeless. She'll comfort the people on the streets who are begging, and dirty. She could be actually the person more infectious, you see? So do not discriminate. Then when SARS happened, SARS in 2003 and H1N1, the Health and Human Services, the Centers for Disease Control, everybody was worried about this additional level of precautions, which we were supposed to be using, but we were not, because this was practically airborne. Okay. So they came up with a set called additional precautions or transmission-based precautions. And this was for airborne conditions like tuberculosis, SARS, H1N1 influenza, MERS, COVID. These are all airborne conditions. Okay? Respiratory, basically. It affects the upper respiratory tract and your respiratory tract. Okay? So we'll talk a little bit about that. So during universal precautions and standard, let me give you a little bit of advice on education through social media and education through a professional group. It's a very different thing. We spend more time on social media, getting information from social media, than a trained group of professionals. Okay, so use this. I'll fall back into social media as I'm talking. During universal precautions, we used to have regular use of hygiene procedures. During additional precautions, they said increase your hygiene. I can't wash my hands 20 times. At least wash your hands before you wear gloves, after you take your gloves off. Every time, do that. We don't do that in dentistry. We just try to slap on some, alcohol gel or an alcohol spray and think that our hands are clean. No, they are not. Regular use of PPE, use a higher level of PPE. Yes, because the N95 or the KN95 or the P100 or respirators, PAPRs, were supposed to be used. Okay? Regular use of barriers on one side, more use of barriers. How much of barriers can we use? We use plastic barriers. Yeah. They're going to fill your landfills. And 200 years from now, if you happen to come back in a time machine, you'll still find those barriers in the landfill. Okay? Regular use of mouthwash. And here they said regular use of mouthwash, but then all of a sudden they said, oh, you got to use hydrogen peroxide. It is more effective than chlorhexidine gluconate or whatever it is. Or you have to use iodine-based povidone iodine. Hogwash. You know, the disease is not purely in the mouth. The disease is airborne. Okay. It comes from your upper respiratory tract. It comes from the oropharynx and the nasopharynx. So do you think that any of the mouthwashes can be introduced into your upper respiratory tract, your nasopharynx and the oropharynx, be it hydrogen peroxide or chlorhexidine gluconate? No. So that is a moot point, and people published papers on that. That was silly. And when I try to tell people, don't do that, just do what you were supposed to do. Use a mouthwash, a pre-procedural mouth rinse, be it a scope or a Listerine or a chlorhexidine gluconate. It's fine. Oh no, does it kill COVID? You know, in my opinion, COVID is a lipophilic virus. You pour club soda or Coca-Cola on that, even thumbs up. Yeah, it'll kill it because, all these solutions we're putting on that has a pH of 3 or 4. And that is good enough to dissolve the coating, the fat coating these lipophilic viruses have, and it denatures them. Okay. Then regular use of germicides, then regular use of germicides on the other side. Regular CDE. People never bothered about continuing dental education till COVID hit. Yeah. Number one, they were getting it free from all kinds of sources. People with absolutely no training. If there was a guy with a blog and a computer, he or she could be training a whole bunch of people because they try and mimic either American standards or Canadian standards. You cannot mimic, you have to practice. To practice, you have to have knowledge. You have to change your attitude. It has to be a daily thing, not only during COVID. Okay. Then regular housekeeping, increased housekeeping, regular waste management, increased frequency in housekeeping steps, specific steps in waste management. There are no specific steps in waste management. The only changes which we really brought was physical distancing. use of respirators like N95s, then use of recirculating devices, okay, air recirculating devices, which had a HEPA filter, okay, taking the temperature of the reduced patient load, 1 patient per hour was what was recommended in the guide. I mean, it was actually provided in the guidelines, but I would call it a recommendation. Okay. Additional screening questions. Have you been in contact with anybody who had COVID recently? I think that's a moot point. Have you traveled abroad? That's a moot point. You know, in COVID-19, that is, the first 5 days when you have your viruses, multiplying like crazy in your body does not show an increase in temperature. It's normally after the 5th day when your viral load starts going down, when you start getting the higher temperature of greater than 100.4, or, I mean, that is in Fahrenheit. And you may have the signs and symptoms of COVID, like cough and body ache and so on. But what if you get the patient within the first 5 days of being exposed, and when the virus is multiplying, that is when they are the most infectious. So we don't have a question for temperature. Even that is moot, I feel. But we have to do what we have to do because the big daddies and the regulatory agencies say that. Okay? Then limited procedures. They said, do not use a cutting instrument with water, or scalers, or a high-speed handpiece, or air water syringe. So there were all these kinds of things which the dentist thought they were restrictions rather than recommendations. Okay? But there are basic control measures you need to follow in dentistry. The first one is sanitization. That is the lowest level. Sanitize means to clean, to wash, to wipe down, to spray a disinfectant on a surface, and the first wipe down to remove most of the dirt, bioburden, and microbes. Okay? This is a prerequisite before you disinfect or you sterilize your instrument. Okay? The next level is disinfection, where you kill almost all the vegetative microbes and not necessarily bacterial endospores. Okay? You can use a surface disinfectant to wipe down surfaces, or you can use germicides, or you can use X-rays. You can use ultraviolet rays. Yeah, 222 to 260 nanometers. But in dentistry, use of gamma rays and ultraviolet rays are a moot point. You cannot use them effectively. I've known that. I've seen that a lot of people trying to get onto, equipping their operatories, their instrument, reprocessing areas, all with UV lights. Yeah, people should not be there when the UV light is being exposed to the place. Right? The next level is sterilization. Sterilization is the ultimate process in the control. Okay? It is a process to kill all bacterial and viral contaminants, including bacterial endospores. And then when we invest those sterile instruments or materials into a broth, it should not show any regrowth of microbes. Okay? That is the true definition of sterilization. In dentistry, we use autoclaves, dry heat, ovens, and so on. Autoclaves are the most important ones. Okay? It does not matter whether you use an N class, S class, or a B class sterilizer. As long as you use an autoclave, you're fine. And I don't know where the standards are going in most of these countries, because we'll talk about that when I approach sterilization, and I'll show you where the whole world has gone wrong in sterilization monitoring. Here we have to sterilize all the reusable items which are considered sharps or that go into the oral cavity. Now, Earl H. Spalding was a scientist at the Centers for Disease Control, and he devised a classification called Spalding's classification for germicides. Walter Bond from the Hospital Infections Division modified it and said, for dentistry, let's talk about surfaces. We have critical surfaces, semi-critical surfaces, non-critical surfaces, and environmental surfaces. In critical surfaces, these are items that are sharps, reusable sharps, or single-use disposable sharps, sterile sharps. Okay? Anything that pierces the mucosa or skin must be sterile. Okay? They should undergo sterilization, or they should be single-use sterile disposables. The next level is semi-critical surfaces. These are items that do not enter the oral cavity. They're not sharps. No, sharps, we know, scalpels, the surgical instruments, the scalers, and so on. They are sharps. Okay? But the semi-critical items are like mouth mirrors, handpiece, amalgam condensers, saliva, and high volume evacuator tips. These also must be sterile, or they could be sterile single-use disposable items for surgical purposes, or they could be clean supplies like the plastic saliva ejectors and the high volume evacuator tips, but they should be maintained clean. So the critical and semi-critical surfaces must be sterilized, okay? Or they must undergo the highest level. The non-critical surfaces, such as your bracket table, your work benches, your light handles, light switches, your chair controls, all of those can be disinfected, or you can use a barrier in between patients. Then you have the environmental surfaces. The environmental surfaces are walls and floors. Okay? These are some of the things which you have to understand. I want you to review all these charts because you'll be getting these in your handouts. Okay? So here are sharps, non-sharps, high-touch surfaces, environmental surfaces, and so on. Then you have concepts. Okay, we have to actually go ahead and review this, understand this first. So when you're reviewing this video, please look at it over and over again till you understand. Okay? What are the diseases commonly impacting dentistry? There are multiple diseases, multiple infectious diseases. But here is something the Centers for Disease Control in 2003 put out. They said, if you or any of your staff in the clinic are not feeling well or have any of these conditions, don't come to the clinic till you resolve those conditions. Conjunctivitis, staph, strep, viral respiratory, TB active, okay, influenza, pediculosis or lice, herpetic whitlow, herpes, orofacial herpes, then varicella, shingles, hepatitis B, E antigen positive. If you're E antigen positive, there are restrictions, just like HIV. If you're highly infectious, you're not supposed to be doing clinical dentistry. Okay. If you have hepatitis C, the CDC says, no, you don't have any restrictions. But as far as India is concerned, as far as other countries are concerned, I would say if you're hepatitis C positive, you must be treated for that. And only after you're proven negative can you be allowed into clinical practice, because Hep C is a very infectious disease. Okay. It's 300 times more infectious, I feel, than HIV. It's about 50 times more infectious than hepatitis B. If you look at, Eli Capilouto's article, he explains that, using a probabilistic model. HIV is the same thing. If you have high viral load and low CD4 counts, if you're in the AIDS stage and you're not on your medications and you're not being monitored, you should not be in practice. So these are some of the things: measles, mumps, rubella, rubeola, pertussis, diarrhea, enteroviral infections. If you have active hepatitis A infection, and of course, if you have COVID, if you have active COVID. So these are some of the common infectious diseases. Let's go over these. In this chart, look at all these infections, look where the habitat is, okay? And look at the routes of transmission. So you have sexually transmitted diseases, respiratory diseases, childhood diseases, and other common conditions, So here are some things, This looks like, you've gone to Casa Piccola in Bangalore. It used to be there. They used to make a pizza. Hot. You take the first bite, it burns your palate. Yeah, it could look like this. But if you look at the rest of the body, if you have blebs, what do you think it is? Chicken pox. It could be like this intraorally before it could actually hit the rest of the body. Here's a child with nice chubby cheeks. What is it? Probably mumps. Then fecal oral route. These things can happen anywhere. It can happen in the best of the parts of the world and the worst of the parts of the world. These are, fecal oral route. If you don't wash your hands and you serve people with dirty hands, okay, you can pick up hepatitis A or hepatitis E. Hepatitis A, anybody can pick it up. Hepatitis E, it's normally found during pregnancy. Okay? Then hepatitis B infection. That's a very common infection. Everybody in dentistry, anywhere in the world, who's going to be doing dental practice, be it a dentist all the way down to a dental assistant, they must get their hepatitis B vaccinations. Okay. Now, if you look at India and South Asia area, the disease rate is between 2 to 7% among the population. Okay. Now, let's talk about hepatitis B. When you first are exposed to hepatitis B and you pick it up, as long when you're not protected, okay, one person may die, on exposure, the first, role of the disease. Then about 20% of the people who are exposed turn into carriers. They have it for the rest of their lives. They are carriers. They are highly infectious. They have a very high viral load. Okay. They have a subclinical scenario. Most of these people will end up having hepatocellular carcinoma in about 10 to 15 years. They'll have a high surface antigen and E antigen. Okay. Now, the rest of the people, about 79 to 80%, are protected. Okay. Then, so make sure that everybody gets your hepatitis B shots. I got mine in 1988 when I was in Kidwai as a cancer research officer, research officer dentist to the Indian Council of Medical Research. Okay. So hepatitis C, this one is a very infectious disease, and it is present in India too. I mean, it's associated with blood transfusion, but I feel that most of these are either through using or sharing needles, in drug abuse, and you also can pick it up sexually. Okay, so you can choose whichever way you think is more important. Okay, now it is parentally transmitted, and we are kind of between 1 to 2%, at risk in South Asia. Okay. You can look at the chart and see the rest of the world where it is. Okay. Then you have hepatitis D and hepatitis G. These are two newer infections that were identified in the past 10 to 15 years ago. Hepatitis D is a piggyback virus. It only occurs as a co-infection or a superinfection of hepatitis B. If there is no hepatitis B, there's no hepatitis D. Okay. It's also not uncommon during pregnancy. Hepatitis G infection is the most recent one. It's also a blood-borne condition. Okay, they're still trying to identify it. It is transmitted through blood and sexual contact. Okay. Hepatitis D. Hepatitis D is pretty low in India, probably because there's not much of testing and reporting. Let's see where it goes. HIV is one of the biggest. I think it is bigger than the Spanish flu of 1918. Okay, they call it the Spanish flu, but it's not really from Spain. It could be from the Americas too. So anyway, HIV was identified in 1981. Okay, in the US, there's at least 500,000 people to 1 million people that are infected. Okay. Initially, it started off as diseases only seen in the homosexual male population. No, today we see it in every different segment of the society. Women, children. HIV is also on the rise in younger people, younger populations who are sexually active. Okay? Worldwide, 1.7 million people become newly infected. Okay? About close to 750,000 die every year. Okay? Look at these numbers. These are big. Okay? So in dentistry, it's normally associated conditions which we see are hairy leukoplakia, necrotizing ulcerative gingivitis, periodontitis, candidiasis, and Kaposi's sarcoma. When I was an infectious diseases fellow in San Antonio, I used to frequently treat patients, at the Grayson Street Dental Clinic, which was purely for HIV patients. Almost every single patient had these oral conditions. Okay. Oh. Oh, I'm sorry. There's a small glitch which I need to get rid of. Hold on. Okay, let's go to this one. Hold on a second. There's a slight problem here. Okay, sorry about that. So this is how HIV spread. 1983, there were about 1,000 cases. The little yellow dot, each yellow dot is about 30 cases. In 85, look at this. There's a thicker concentration of these yellow dots. In 89, there were 100,000 cases. Okay, it's become darker. Then in 94, look how thick it looks. It looks like how the United States looked from the moon, if somebody, or from the space, if somebody took a picture of the United States at night. Okay. So the comorbidities you see in HIV are protozoans, fungal conditions, viral infections. All organ systems may be involved. Okay. Multi-drug resistant tuberculosis and extremely drug resistant tuberculosis is not uncommon. I used to go for grand rounds during my fellowship along with the infectious diseases group, okay, from the medical school. And since I was the only dentist, they used to ask me to go into the TB, negative air pressure rooms and have a look at the patients who had complaints. Chief complaint was toothache, pain in the mouth. I had to wear an N95 mask and walk in. Those were painters' masks at that time. But then I started using P100s. And later I found out most of these patients who had the TB were also HIV seropositive. Okay? At that time, we didn't know multi-drug resistant tuberculosis existed in these patients, or extremely drug resistant tuberculosis would happen. But they were possibly the thing, but luckily I'm still kind of negative for that. Other than the 6 Florida cases, which the dentist called David Acker infected, there has not been a single case of disease transmission as far as HIV and AIDS, HIV is concerned, through dentistry. Okay. Then when you have an exposure, they test you for HIV using ELISA and Western blot. ELISA is a sensitivity test. It shows disease in the presence of a disease. Then the second part of the test is the Western blot, which shows no disease in the absence of a disease, that is. Okay, that's a specificity test. Initially, they do a screening test and then they put you onto the diagnostic tests. So HIV, the high-risk groups are multiple sex partners, heterosexual, homosexual, bisexual, then intravenous drug users, hemophiliacs, blood transfusion before the spring of 1985, steady sexual partners to any of the above 5 groups, infants born to people with any of these 5 groups. So almost everybody is at risk. So let's talk about HIV infection. You may have an exposure, no infection, lucky. Okay, exposure, then you get an infection, it can go into acute disease and AIDS within a span of 4 to 6 years. Okay, or that is if you're not treated. But if you're treated, it's a totally different story. Then the other option is you can go into persistent generalized lymphadenopathy, where 3 or more groups of lymph nodes are affected. But your viral loads don't go really high. Your CD4 counts don't go really low. You don't go into the AIDS stage. Yeah. There is a certain segment of people, like Magic Johnson. For the past 30 years, they've been in the HIV stage and they have not gone into the AIDS stage. Okay. So we know a lot about HIV and so on. But here are examples of the oral manifestations: oral hairy leukoplakia, candidiasis, Kaposi sarcoma, and so on. Now, what is the risk of you acquiring HIV when you're exposed to, a needle stick? Let's say your chances are less than 1%. Now, let's talk a little bit about tuberculosis. Tuberculosis in India is pretty big. Dr. Verma used to invite me to MAIDS. Of course, I used to be his house guest as well at times. And once I met one of the heads from the medical center, Maulana Azad, complex. And they said that multi-drug resistant tuberculosis and extremely drug resistant tuberculosis is not uncommon in India. That shook me. These are diseases you cannot cure, and yet we have to treat them. And think about the doctors going in there. They must be really brave to go and treat them. Okay. About 8 million people are affected every year worldwide. 3 million die every year. This is bigger than COVID. Let me tell you, this is a silent killer. It is ubiquitous. Yeah. In all parts of the world it's seen. And it approaches you silently and gets into you. What I advise everybody in dentistry is at least once a year, go to your county health department or your medical doctor, ask them to test you for tuberculosis. In a study which we actually presented at APIC in the mid-90s, when I was doing my fellowship, was studying the dental students, medical students, nursing students, who had just come into the clinical area of their training. We tested them before that, and then we tested them after the first year. About 6% turned positive for TB. I'm talking of the United States in San Antonio. Okay? Pretty advanced place, So this disease is a silent killer. Okay? India. Okay? It's higher than moderate. Okay? So we need to be careful as to where we are. The main culprit is Mycobacterium tuberculosis, which causes pulmonary TB. Okay? Signs and symptoms: night sweats, malaise, weight loss, fever, fatigue, chest pains, cough with sputum, possibly tinged with blood. You need to ask these questions to every single patient who walks into your clinic. If you have any of these 3 or more of these conditions with active cough for more than 3 weeks, then you may want to defer the treatment and tell them, why don't you get checked for TB? You're not refusing treatment, you're just deferring it so that if they are positive, they get treated for a month or so and they deemed non-infectious, they can always come back. You see? Now, what's the skin test? It's called purified protein derivative or a Mantoux test. They inject a small amount right under your skin. Okay. And if this wheel goes above 5 millimeters, it's a difficult thing. That means you could be positive for TB, or in India, of course, we're all immunized with the BCG vaccine. We'll all show that. Okay. But at least I would say, if you do not want to get the Mantoux test, sometimes people react adversely to this. I would ask you to go ahead and get a chest X-ray and it read by a pulmonologist or a specialist in TB, not by a general practitioner. Okay? They will look for the lesions in your lungs. They'll compare it to the previous, years or the year before, and see if there's any new lesions that have come up. Okay. Now, The other thing is, if there are any new lesions, they'll take a AFB smear, acid-fast bacillus of your throat. Okay? So on. These are some of the things. Now, the common conditions this is how I study the diseases, both as an infectious diseases guy and an epidemiologist. Okay? I am a shoe leather epidemiologist. I'm not just a dentist. Before I even became an epidemiologist, I went into 72 villages in southern India and covered every single person in that village, screened them for oral precancers through Kidwa Cancer Institute, and the Indian Council of Medical Research and WHO. Some of you know that, and some of you don't. But I spent 3 years with a team of 15 professionals, and I was the team lead. So I am a shoe leather epidemiologist. But other than that, as an armchair person, okay, during SARS, I was helpful in implementing how we see patients. What we do during COVID, I implemented that for our school in 2003. When H1N1 came, we solidified that. We used to allow patients only after taking the temperature and asking them questions. And then we'd but by then, even the CDC hadn't solidified their additional precautions. I break it out. I basically kind of flesh out what a disease is. Okay, this is for SARS. This is for H1N1 influenza. We had Ebola, the first case of Ebola in the US, in Dallas. And this is how I flesh it out for COVID. And I will only have this chart probably in the middle of next year, because we are still in the middle of this beautiful, horrible pandemic. I call it beautiful is because it's something which I've never seen before. But at the same time, it is like Yama, as we say, right? He's a god, but he's a god of death. You see? So, I look at the types of viruses, the source of the viruses, common types affecting animals, commonly affecting humans, SARS-CoV-2. What exactly is that disease? Public health measures, risk for dental professionals. I defined contact even before the CDC and any of these guys came in. I defined what contact was when we are exposed. Okay. Then there are ethical issues, economic issues, treating patients during COVID, treating after COVID. We are still in the middle of COVID in India. And I'm very sorry to see, it has gone so low. Treatment after COVID in other countries. Okay. This is where I am today, and we still haven't seen the fall of COVID yet. So this chart will be there next year. We even published a paper, Dr. Chandrasekhar from Amrita College and a few of the other people and I, we published a paper on COVID right during the COVID pandemic in the US. Yeah. These are some of the diseases which, we don't know where it's going to happen, when it's going to go away. But we try and do our best in dentistry. Okay? So this is the end of my presentation, and I'm open to answer a few questions. Arpit?
Yes, sir. I'm just waiting for Professor Mahesh Verma. Verma, sir, you have to unmute.
Yeah, okay. Yeah, thank you, Raghu, for giving a rationale and the concept of dental infection control. And I think some of your statements are so important, and I think need to be carried home. And I think very nicely give a background that how who were the pioneers, how it all started, and what are the routes of transmission, and how the modern infection control guidelines came up. in 60s and 80s, and when we had hepatitis and AIDS, and what is the rationale actually? What is the normal times, and standard protocols, and what are the protocols during pandemic and endemic? As you said that normal times are different, and during pandemic it is different. And I think one more very nice statement you said, that the education through social media and professional groups is different, and we usually try to ignore that. We try to learn, even though we are professional, we try to gain everything from the social media and try to disseminate, and that could be wrong. And also you said that don't mimic, but practice standards with knowledge. You said for practice you need knowledge, and what we tend to do is we try to mimic the standards. But I think more than mimicking, what is most important is practicing it, practicing from within. And also you very nicely demonstrated, nicely explained what are the basic control measures which are to be followed, what are the concept when somebody is sick and not to be treating patients, and how's the transmission normal routes. And you showed through your graph that most of the transmission is oropharynx. Of course, in some cases it could be fecal-oral also. And you also touched upon different conditions which is very commonly affecting, and some of them very dangerous, like hepatitis B. And you said that everybody should get a hepatitis B shot or vaccine. And also you talked about tuberculosis, which we don't suspect but could be more dangerous. You said it's approaching you very slowly, and can be very, very dangerous in India, where every second or third person could be a potential tuberculosis carrier. So we must ask every patient any symptom of TB. And you said that COVID guidelines are still going on, and you're still not formed it. And as the pandemic is still on, and it will still take some more time to gather more information, because as we all say that we are still groping in dark, we're still learning what is the cause, like a problem of mycorrhizasis, that why people were using steroids left, right, and center, and why it has just come up now. So all these enigmatic things, complex things. But thank you so much. I think you built a nice background for the next 4 sessions. And at this point, I don't know whether, Arpit, is there an option of chat box, some questions? And I think I see only one chat box. For certification purpose, use this link to mark your attendance for today. So that is there in the chat box. But I think you have aroused a nice interest, and it is so much vital. And as you said in the beginning, it is something we all assume we know, but we realize where we don't know. So much we don't know. So let's thank you, Raghu, for your wonderful presentation. And I don't know how these handouts, as you said, could be shared, or it could be maybe on the website or something, so that everybody can access. I don't know. It is Arpit and Dr. Rajiv Chugh and Dr. R.P. Gupta to figure out how people can have access to some of those charts and some of those some of those information which you said is one is expected to go through and acquaint themselves. So, but at this juncture, let me hand over to Dr. Rajiv Chugh for further carrying out the further rest of the ceremonies of the program. Thank you.
Thank you. Dr. Chugh needs to unmute.
Meanwhile, I'll just take 30 seconds for some housekeeping announcements. Point number one, we will be taking question and answers in the next session, that is on the coming Sunday, again at the same time, 6 p.m. Indian time. And you can email us the questions on IDA Chandigarh branch at gmail.com. I'll be posting these details in the chat box as well. And apart from it, the attendance link has been shared in the chat box. You can, for certification purpose, those who are willing to get the certificate, attendance is mandatory for all the sessions. So you can very well go to the link and mark your attendance for the day. And now I hand it over to Dr. Rajiv Chugh.
Thank you. Dr. R.P. Gupta, President, International College of Dentists, India, Sri Lanka and Nepal Section, and Indian Dental Association, Chhattisgarh State Branch. Eminent speaker of the event today, Dr. Raghunath Pataya. Fellows from the ICD International Head Office, members of the Board of Regents of ICD Section 6, Executive Committee members of IDA Chandigarh State Branch, dear ICD Masters and Fellows, and dear colleagues from all across the world. It's a matter of great pride for me to have been asked to offer a vote of thanks on the occasion of the certificate program on infection control and occupational safety in dental practice, initiated by the ICD International Head Office in collaboration with the ICD Section 6 and IDA Chandigarh branch. On behalf of the organizing team, I wish to extend a hearty gratitude to fellow dear Dr. Raghunath Pataya, who is an authority on infectious diseases control in dentistry. I must mention our deep sense of appreciation for Dr. Raghu for taking out time from his busy schedule and enlightening us with his knowledge. We have been fortunate to have him conduct an inspiring and informative lecture, first in the series of 5 lectures under the certificate program. I'm pretty sure the precious knowledge that Dr. Raghu gave us will definitely help us in our dental practices in the future. I would like to express our sincere thanks to ICD International Head Office for conducting this program with ICD Section 6 and IDA Chandigarh State Branch. This certificate program is being offered to the dental professionals in India without any registration charges, whereas worldwide it's a paid-up program. Thank you to the office bearers from the head office. I'd like to acknowledge our gratitude to the Board of Regents of ICD Section 6 and the organizing committee of IDA Chandigarh branch for putting together this event. I appreciate the contributions made by Dr. Mahesh Verma, Vice Chancellor Guru Gobind Singh, Indraprastha University, and Chairman of Continuing Dental Education, ICD Section 6, for his involvement in the project since its inception. He extended the invitation to Dr. Raghu, gave his own valuable inputs, and has been personally involved in the execution of this program. My sincere thanks for Dr. Anil Kohli, the past President, Dental Council of India, and International Councilman of ICD Section 6, and Dr. Rajesh Chandna, past International ICD President, for their coordination with the International Head Office. Thank you, Dr. Arpit Gupta, Secretary, and the Office Bearers of IDA Chandigarh State Branch for managing this event so well. It has been our tribute to host all the fellow members and audience of the meeting. Your overwhelming response has been extremely encouraging. The International College of Dentists is a leading global honorary organization dedicated to the recognition of outstanding professional achievements, meritorious service, and to the practice of dentistry for the benefit of all humankind for more than a century. ICD Section 6 is a 57-year-old section and rated as the best section in the world because of the numerous activities carried out all across India. Please visit our website www.icdsection6.com to know more about our section. I want to extend my generous thanks to everyone associated with this program. We look forward to your participation in the next session of the program on 30th of May 2021 at 6 p.m. Indian Standard Time. Till then, take care and God bless.
Thank you. Wonderful.
Thank you, one and all.